All right. Thank you, everyone, for the opportunity to hear me talk a little bit about the way that we kind of envision CRISPR being used with opportunistic infections. I'm here at Ohio State, so we're on land that was caretaken by Miami Wyandotte and the Eastern Shawnee. Ohio State still lays claim to most of that land and still makes a lot of money off of that land as well. So here at Ohio State, I kind of sit at the intersect between arts and sciences and the School of Medicine. And we kind of reside as one of the major cancer centers for this area of the Eastern lower Midwest. And when you're dealing with cancer patients, immunosuppression is a given at this point. And a complication with running immunosuppression for things like cancer treatment or transplant is the risk of opportunistic infections that take place or common infections that take place during those treatments. You're currently seeing around 19.1% on average, depending on the kind of transplant or cancer treatment or autoimmune disorder that presents in the clinic, being complicated by an opportunistic infection. The really difficult part of that is the fact that it's almost going to be impossible to prevent infections from happening. We're dealing in a world that is populated by more microbes than there are people. So trying to prevent all microbes from getting into a space is really, really challenging. This is also going to be a continuing problem because of the spread of current approaches that are used here in the US around medicine to other parts of the globe where they're not practiced currently as often. And the fact that we're dealing with a continuously aging population and the rates of these infections increase in the elderly, even under immunosuppression, which is really interesting when you think about it and kind of gets into the complexities that exist around innate versus adaptive immunity. So if we're thinking about the kinds of agents that cause these infections, we're dealing with literally everything. Viral, bacterial, and fungal, kind of in that order of prevalence. Here I'm showing data specifically from pneumonia that comes from autoimmune patients. And you can see that we're running the gamut, everything from influenza all the way down to mycobacterium and tuberculosis and fungal infections like Candida. So you can't just try and treat against one opportunistic agent when you're dealing with an immunosuppressed patient. And if you look at different types of treatment regimes that are going on in the clinic, there are different species or different kind of categorical taxa that are more common agents in these infections, depending on exactly the condition of the patient that's being treated. So with acute leukemia, you're seeing that gram-positives kind of went out. When you look over at heart transplant, it's the gram-negatives that are typically more prevalent, the enterobacteria, the enterococcus that are shown here. And this increases over time to be more dominated by things that are fungal and viral, which is kind of interesting. So we need to be very adept at identifying the infectious agents that are more likely to be seen based on the patient that's coming in the clinic and combat those infections from taking root during other surgical procedures. So we're kind of in this tipping point between resisting infection and permitting the procedure to take place. Now, if we're dealing with transplant specifically, we're dealing with a graft situation where we're inserting tissue from a donor, not the patient themselves, into the patient's system. And we're dealing with the possibility of rejection. That rejection is often mediated by T cell populations that I've kind of depicted here in the middle, going through the process of differentiation from the lymphoid progenitors through different stages, and then finally into CD4 or CD8 positive populations. And so we need to find ways such that we both resist infections, but allow the graft, often an allograft of a non-donor, or sorry, a non-patient donated sample back into a patient. The way that this is currently commonly done is by extracting PBMCs, so aperipheral blood mononuclear cells. These are progenitors that are going to become T cells, B cells, and NK cells. You then can proliferate them and expose them to different drugs, things like mycophenolic acid, things like calcineurin inhibitors, and things like glucocorticoids that all suppress T cell activation. And then you immunosuppress the patient that's going to receive transplant and add in these PBMCs, hopefully from the patient themselves, an autograft, or maybe from some other donor, an allograft, to reconstitute their immune system around the graft itself. So you're trying to provide this balance again between resisting infection by providing some adaptive immunity without allowing the adaptive immune response to reject the organ that's being given to the patient.
At 5 minutes, and we are seeing your presenter, or not the presenter view,
I'm sorry, you're seeing that better?
We're seeing the display view.
Yeah,
Great.
that looks better now.
I'm sorry, that has not happened to me before.
First time for everything.
Always true. So these inhibitors are often given to help suppress the immune system of the patient itself as it tries to rebound from the immunosuppression. So things like calcineurin inhibitors are inhibiting calcineurin so they don't activate these T cell populations in the patient's own system. In the graft, at the same time, you can modify calcineurin in the PBMCs that are donated back into the patient's body such that they can activate an immune response. And the way this is typically done is by training those donated lymphocytes, those T cells, to recognize certain pathogens. And this is most commonly carried out using a targeted knockout, but has been switched to really a CRISPR approach where you hit calcineurin and give it a donor template that modifies calcineurin so it's no longer able to recognize the specific calcineurin inhibitor that you're using, typically FKS 506, which is the most common calcineurin inhibitor. So you can give people these modified lymphocytes that are able to respond to pathogen in the presence of calcineurin inhibitors to keep the patient's immune system down so it doesn't reject the graft. So the way this typically looks is you extract the PBMCs, you expose them to the organism. And I think the modification and the approach here will be exposing them to a battery of organisms specific to that patient's kind of current condition. Because again, those organisms are going to change depending on the kind of procedure that the person is there for. You can then selectively enrich for T cells using CD4 and CD8 type of gates after stimulation with interferon gamma. You can then CRISPR in that calcineurin mutations such that they don't respond to the calcineurin inhibitor and reconstitute those into the patient. So they're able to recognize and they're primed to recognize pathogen without rejecting the organ that's being transplanted. So in taking this approach of how we're going to use CRISPR to prevent opportunistic infections, this is a very host-centered approach. We're modifying the immune cells without modifying the host long-term by doing all the modifications within a cell culture framework and then putting those back into the patient so they can provide that function that's really required that again has been extremely problematic within these kind of scenarios of immunosuppression. The other approach that I kind of want to posit as an option here is instead of attempting to modify the host so it can recognize pathogen, altering the organisms that are likely to cause opportunistic disease. And this is where my lab spends a bit more time. So we work on Candida albicans, which is a fungal commensal of humans, residing fundamentally all over your system. When you undergo immunosuppression, it's able to proliferate beyond kind of the natural boundaries within these systems and cause mucosal infections and then deep tissue systemic infections. Now, opposed to bacterial pathogens, the lethality rate of these tissue infections for fungal organisms is around 50%, which is really frightening. Bacterial pathogens, you're usually looking at mortality rates of around 5%. And the way that they cause a systemic disease is by moving from a yeast phase into a hyphal phase and gaining access in your bloodstream. And so a lot of people have tried to move past antifungal drugs into antivirulence drugs. So how can we prevent this transition from yeast to hyphae? And I think we might be able to move into better systems beyond these antivirulence drugs, which attempt to inhibit hyphal formation by using CRISPR to design Candida that is forced to remain in a yeast state. And so what we could do is we could insert specifically a hyphal promoter in front of the MCA1 gene, which is the megacaspase that exists within Candida albicans. When Candida would attempt to go hyphal to invade systemically, then we get overexpression of the MCA1 gene, which leads to cell death. The caspase becomes overactive, degrades all the proteins within the cell, and the cell ends up undergoing apoptosis or necrosis. And so there are two complementary approaches that I've kind of introduced here that I think CRISPR could be very valuable. One is training the immune system to be able to see a plethora of pathogens that are going to be important for a specific disease context. The other is re-engineering organisms that already live with us such that they're unable to cause disease very well within a host system. So during immunosuppression, the possibility of opportunistic infection is incredibly low compared to what it is now. So with that, I'll just thank folks in my lab and then folks that we're working with to help kind of see some of these ideas come to reality. Thank you.